He is again heads the Department of Cataract Services and more at Chaitanya Group of Hospitals based at Trivandrum, and is a man with not just great surgical skill, but a huge quota of common sense. And he comes with the most beautiful tips in his talks wherever you hear him. And he is going to tell us about approach to posterior polar cataract, his pearls.
So thank you, madam. The thing is the femto. If you have a femto, that is the ideal way to do. I will do all post-polar cataract with femto delineation. So you get delineated as already shown by shale, but then you get this cylindrical cuts, and it's like a delineation without any hydro procedure, and you can gradually go around it and aspirate it off. Once it is finished, then comes the outer epinuclear shell, which I basically use the phaco probe and my blunt tipped 2 mm chopper, which is used to go around and mechanically separate. I can show you the viscose separation in another case, and mobilize it out, and then see this. Then always take out irrigation after replacing the anterior chamber with viscoelastic free filling, because any shallowing or hard deepening can open up this kind of weak areas, and then most of the cases you can get away with it. Here is a second case with the already open posterior capsule. So Rex is very important. This is my coring technique. So this goes around the nucleus with minimal aspiration and adequate energy, and the central core is taken up. And the periphery now, I use my 2 mm blunt tip chopper, go to the periphery and mobilize it gently so that all the epinucleus comes out from the equator, and towards the end, we can lift it out. Basically, it's not rotating. It is lifting out of the bag mechanically. And also while exchanging, replace with viscoelastic. And I use basically bimanual in this. When you're exchanging again, use viscoat or sodium hyaluronate. And many times you may not get vitreous out. If you get vitreous, you have to do a vitrectomy. This was lucky, and you get this kind of a pillar-like opening. And I use always a 3-piece lens. And if your rexus is 5 mm or smaller, this is slightly larger, but it can be used to capture your rexus. Here again comes a third case with a harder nucleus. So here no hydro, no rotation. First chop and second chop, and slightly slowly extend and then take out that piece. Once that is done, go towards the left. Again using a sharp tip chopper. One more chop. Go towards the right. One more chop. So 1/3 of the nucleus is gone. No rotation. Now I change my chopper tip to the blunt tip. Go to the equator, cross chop. Separate the one more piece, and now 1/2 of the bag is free. See, now this is lifting up the nucleus. There is no rotation. It is lifting it into the free space in the center. Again, go beyond it, beyond the equator, and lift it up. And once it is in the anterior chamber, it can be completely emulsified under viscose cover. So no chamber fluctuation, very, very important. No too much of deepening. And now this is the visco dissection, which can definitely bring out a lot of epinucleus, which is there in the periphery, assisted with my mechanical movement, and you can aspirate. Now this is a classical posterior polar, and after taking out, you can see sometimes there are very thick plaques. Most of it can be just left and you can yag it later, but in the center, if it is too thick and too large, you can try to separate it, but most of the times it will come with the posterior capsule. So if it cannot be separated, we can also do a posterior capsule rexus on the primary sitting. Also include this area, do it just beyond it, and rotate it like your regular posterior polar posterior capsular rexus, and complete the posterior capsule rexus. So the plaque is also gone. You mostly do not get vitreous disturbance if you have a little sodium hyaluronate on top. I place a 3-piece lens into the sulcus, and to capture it properly, I would like to evacuate the bag relatively. So I go in with minimal aspiration flow rate and aspirate the sodium hyaluronate. I use only sodium hyaluronate, don't use HPMC. But later on, if you have a slight bit of doubt that you are aspirating vitreous, please, I'd use a vitreous cutter and cut the vitreous. And now you can see that this is a adequate capsular rexus where I can capture the optic and the central rexus margin. Thank you very much. 4 minutes. I had to stop 4 minutes. Thank you.
Yes, yes. Amazing talk. So Tamil, take his questions.
Sir, have you tried oval rexus in PVC, sir? Or?
I'm sorry. Your question was totally broken. I couldn't hear. Voice was broken. Once more.
Oval rexus, sir.
Oval rexus. I've heard. I've seen people do oval rexus, is it not? Yeah,
Yes.
yeah.
Yes.
I have seen people doing oval rexus, and there are some advantages that you can use that extra area to do all those. But then towards the end, if you want to capture optic properly, should be a round rexus and a smaller rexus. So I will tend to do a round rexus rather than an oval rexus, although it has some advantages like using the extended area for more chopping and taking it out and all.
Oval
should
rexus, you should
question
ask
to
Kiranjit,
Kiranjit.
Dr. Kiranjit only. He is
Yes,
the
please.
man who initiated the oval rexus. So how could he not be asked? So tell us
So,
about oval rexus very briefly.
oval rexes will give you advantage of both the small and the large rexes. Large rexes for taking out the nuclear segments out, and if in the end you get a PCR and you are not able to put the lens in the capsular bag, you can optic capture a 3P piece lens in the sulcus. So it has advantages of both small and large rexes.
I
So,
think Tamil, you should tell about your experience with the ASOCT in posterior polar cataracts.
Yeah, that's what I mean. I missed that. Nowadays, I'm doing in every case, and I was stunned one day to see Dr. Ramurthy easily rotating one nucleus in a live surgery in a post-polar cataract, and nothing happened. And he totally believed the anterior segment OCT. And nowadays, I also started believing anterior segment OCTs. Actually, anterior segment OCTs are very good guides. Maybe sometimes, but then there are some gray areas. But most of the times, they are very good things. Tamil, please, you please highlight this.
Tamil?
Tamil just went off.
Yeah.
She got maybe disconnected.
No. She's a smart guy.
She got disconnected
Got
maybe.
disconnected. So we'll come back to Tamil's question. Let's take Tamil. Are you
Yeah,
back?
she's back. Yeah.
Tamil?
Yes, ma'am. Yes, ma'am. I got disconnected.
Yeah.
Yes, sir. Actually, ASOCT has a high negative predictive value. So it means if the PC is intact and traceable beyond the opacity, it means that the likelihood of PCR is very less. So we started doing, and we all know that if you're going to do a hydrodelineation, taking out the epinucleus sheet is going to be challenging and more chance of PC dehiscence. So in cases where the PC was traceable, and we did a gentle hydrodissection and nuclear rotation, and we proceeded like with routine phaco-parameters. And we also took precautions like maintaining the AC stability, and we do not go and do a PC polishing with a aspiration cannula, but we did a hydro polishing. And the second group where the PC was not traceable behind the opacity, we did the routine hydrodelineation, and we didn't rotate the nucleus, and we followed all the precautions. And only in the initial one case, we had a PC dehiscence following a hydrodissection, and most of the cases, like we had around 56 eyes and 55 eyes, it was like a routine phaco with gentle hydrodissection. And we could even implant a premium lenses in these cases. So ASOCT is done routinely, and based on that, we decide whether we can go ahead with the hydrodissection or not.
Thanks,